This podcast was produced from a webinar. For a more interactive experience with visuals, visit myamericanNurse.com/webinars.
Welcome to this American Nurse Journal webinar, Challenging and Inspiring Beyond Common Fall Prevention Practices. I want to thank our sponsor, Colette Health, for providing the unrestricted educational grant to help us develop and present the webinar. Thank you for joining us today, and I think you'll find what we'll be talking about today very, very important to clinical practice. I'm Lillee Gelinas, your moderator and also contributor to the content for today. I'm editor-in-chief of American Nurse Journal. I'm also assistant professor at the University of North Texas Health Science Center in Fort Worth, Texas. I'm a certified professional in patient safety, and therefore the topic of falls prevention is obviously very important, not only to me, but to all of us nurses. Our objectives for today: recognize the difference between known fallers and at-risk for falls patients. What an important differentiation. Describe fall risks reduction through individualized fall prevention management to promote patients' function, independence, and safety. Elevate the prominence of emergency departments within the care continuum as a critical point of care for fall prevention. Those are the objectives, but this is what we want for you as your takeaways. Organizations must stop over-reliance on fall risk scores. As nurses, we've all learned fall risk scoring, but you're going to hear a counter to that. Emergency departments are the critical point of entry for known fallers, and fall and injury prevention for known fallers must be individualized based on fall etiology. Joining us today is an esteemed expert on the topic of falls and falls prevention, Dr. Patricia Quigley. She's president of Patricia Quigley Nurse Consulting, LLC. But I just want to tell you, I've known her for many, many years, and she clearly is distinguished in the fall and injury prevention realm of topics. She's a prolific scientific scholar, published in multiple peer-reviewed journals. And most importantly, she's an impactful and articulate scientist. She'll be discussing with us today this important topic about how do we incorporate best practices to reduce preventable harm related to falls. So with that, I want to turn the mic over to Dr. Quigley to get us started on understanding just how great the burden of falls really is in the healthcare arena. Dr. Quigley.
Thank you so much, Dr. Gelinas. And I just cannot tell you, before I get started, what an honor and a privilege it is to be here with you, to be able to discuss this topic, which is my life's journey and my life's commitment, falling for injury prevention. But to thank you on behalf of the entire nursing profession, all nurses past, present, and future, for your leadership in patient safety, Lillee, and also for being the editor-in-chief of the American Nursing Journal. I just can't thank you enough for the years of experience that you and I have shared over the years on advancing the importance and the voice of prominence of nurses in fall and fall injury prevention, because the burden is great. So I am honored and privileged to be here with you. I'm just so excited. So colleagues, I want to thank you so very much, as well as Dr. Gelinas did, to thank you for your interest in this topic and the importance that this topic has for all of us and the aging population that we deal with and we care so much about. But also because the American Nurses Association has for years and years and years, decades, taken a leadership on addressing fall and fall injury prevention as a nurse-sensitive indicator, even though it is interdisciplinary. So colleagues, I'm so committed to helping us all appreciate the burden of falls, because it is great. You know what? Every minute counts. CDC's analysis of 2019 unintentional injury deaths helps us to know that falls were the leading cause of unintentional injury death in the entire U.S. population. This is across all age groups. Falls was also the leading reason for unintentional injury death for older adults, 56.5% of all causes of unintentional injury death. And this is older adults. Every year, 3.7 million Americans turn 65, and I'm proud to say I'm in that age group. And according to Factora and others in 2021, adult ages 65 and older, we're twice as likely to fall than younger adults. So every year, more than 1 in 4 older adults will fall, and that includes me. More than half of those who fall don't tell their healthcare provider. And I have to tell you, Lillee, this is so important to me because I know that adults won't tell their healthcare providers, but you know what? Oftentimes older adults who live alone won't even tell their families. Don't you know that that's true?
Absolutely.
Absolutely. So every 20 minutes in the United States, an older person dies from a fall, and we know this from CDC. So this is absolutely compelling. When you think about every second an older adult falls, as I just mentioned to you, that's about 1 in 4 adults that will fall, 28% over the age of 65. And I do focus on older adults because of the risk of loss of function or loss of life when they suffer certainly an injurious fall. But when you think about this, this results in 36 million falls each year that are occurring. More than half of those, as we mentioned to you, will not even talk to their healthcare providers. So you have to do everything you can, colleagues, to try and get people to tell you about their falls. I always start out with my patients and talking about my falls and hoping that they'll talk about theirs. But when you think about these 36 million that will fall, we have 8 million of those who actually will have injuries. When you look at those 8 million that will have injuries, out of those that have injuries, which is about 37%, 37.5% of those will actually be admitted into emergency departments. So as you can see, even with those older adults that are having injuries and the amount of falls that are occurring with older adults, you can imagine and should know in your own communities what this burden is to EMS. Because I know in some communities in EMS that they are responding to help older adults have, if you will, fall to help them be listed back up, even though they might not go to the emergency department. And there's actually partnership with the National Council on Aging with EMS nationally to help deal with this burden. But those who actually do come to the emergency department, those 37.5% that make it to the emergency department, and this is my special focus on emergency departments, these colleagues are what I refer to as the known faller. Patients who fall and actually get rescued by EMS and actually present to the emergency department. Out of those 3 million or 37.5% who actually come into the emergency department, there will be 31.7% or 950,000, this is estimated, that actually will be hospitalized. So every one of you who is on this call, you should know what percent and what numbers are occurring in your emergency departments of those who actually present into your ERs. But I want to give you the other side of the equation. And I always talk about the other side of the equation, just like falls. You have a fall rate and then you have the rate of those who don't fall. I want you to think about the percent of patients who actually get sent home who come into the emergency departments. So you have 68.3% of known fallers who had an injury that presented to the emergency department who actually get sent home, to their home, to a family member's home, to assisted living, to long-term care, post-acute care, or rehabilitation. So that's a huge percent, and that's why I spend a lot of time also focusing on that population. But then sadly, out of all these numbers, we have 32,000 patients, older adults, and dies from a fall, 3.4%. And this to me is just so very sad. And I'm so delighted that we're together to be able to address this because we all own this and we all must do something different. And that's why we want you to recognize the difference between known fallers and those who are at risk for falling patients. So that is our first objective. So I want to differentiate these for you, colleagues, because this is really important. And this is my label, known fallers. If you want to come up with another label, I hope that you will. But, you know, we talk about fall rates and repeat fall rates, but we don't talk about rates of fallers. But when you see who's presenting into the emergency department, these are your known fallers. These are the ones who actually made it. They had EMS, maybe even family members who brought them, that are coming into the emergency department because they fell. With known fallers, absolutely, we need to be able to triage them based on presentation and etiology of the fall. Because how you treat someone who presents to the ER because of a fall when they fell out of a car losing their balance versus someone who is orthostatic versus someone who had a stroke is going to be very different. So that's why in emergency departments, we want to be able to triage. And if someone is injured, of course, the first thing that we're all going to do is to treat that injury first, stabilize medical conditions, and then determine the trajectory of care, which we will be talking about. And then there's all the other patients who are presented to emergency departments who are at risk for falls. Who isn't, unless they're in coma? But, they're all at risk for falls. So that's everybody else. And then we have those who are older adults who are admitted to the emergency department that were not admitted to the ED due to the fall. So we should all be addressing them and then screen for fall risk and then determine their trajectory of care as well. So I want you to spend special attention on those people who are known fallers. So let's describe those fall risk reduction strategies through individualized fall prevention management, because we want to promote patients' function, independence, and safety. And so for those of you who know me, I'm a rehabilitation nurse, and this is always my measure of success, is not just did you prevent their fall, but what fall risk factors did you actually mitigate and eliminate because someone was in your care and improve their function and their safety. So I do want to emphasize to you, and I hope you will have this as a takeaway as well, this article from 2010, which is just a hallmark article by Dr. David Oliver and colleagues, who did a synthesized literature review of fall injury literature around at that time in 2010 that included cohort studies and also behavioral health patients. It was an update of his 2006 synthesized literature review. And there's 4 recommendations. And what we have done for you today is to align these 2 types of falls that are preventable. And now we're moving into some precision. We have moved away from universal fall precautions. So the very first recommendation is we all have a responsibility when patients come into our care, into emergency departments, any point of entry, to implement a safer care environment for the entire patient cohort. And you can see what that is: flooring, lighting, those kinds of things. And that's predominantly what universal fall precautions is anyway, is environmental safety. Well, when you're creating a safer environment, you are reducing accidental falls. You should always be clear when you're implementing interventions, which type of fall are you going after? So this is accidental falls. The next 2 recommendations from this article, which are really important, and I really want you to emphasize this and have this as a point of discussion when you go back to your falls committees, is to identify specific modifiable risk factors. All of us live with risk factors for falls, but some are modifiable and some are not. The ones that are modifiable, what we're supposed to do is we're supposed to treat it. So if someone has postural hypotension, we should work it up and treat it. If someone's got centrally acting medications that can be modified, we're supposed to modify those medications. When we identify risk factors and we develop a plan of care to implement, to mitigate or eliminate that fall risk factor, and I hope you can see me, is we're now addressing anticipated physiological falls. So the 2 types of falls that are preventable in our emergency departments, in our healthcare systems, all across healthcare, in homes, are accidental falls and anticipated physiological falls for the most part. And then the last recommendation in the Oliver's article, which I hope you will really hear these words, is to implement interventions to reduce the risk of injury for those people who do fall, because you have patients who are going to fall in your care. You just want to make sure that they don't have an injury, that they don't have loss of function from an injury or loss of life. So 1, 2, 3, and 4, create a safe environment, work them up for modifiable risk factors. The ones that are not modifiable, we're going to help them compensate for. The ones that are modifiable, we've got to treat. Now you're moving into an individualized plan of care. And for goodness sake, older adults, you've got to protect them from injury when they fall, because you know what can happen to them. So 1, 2, 3, and 4. So let's start with that, reducing the risk for those accidental falls. Let's address environmental safety. And I have 3 solutions that I really want to target specifically in the emergency departments, because we have to, it's our responsibility to create that safer environment. So I think there's a lot of opportunity for stretcher safety. I bet you do too. Wouldn't you think there is, Lillee?
Absolutely.
I'm telling you,
we take it for granted.
Yeah. And the same thing with bathroom safety, because I know in emergency departments, when patients go to bathrooms, there's maybe 1 or 2 bathrooms that they will use, and I know that they're all the same. So we need to talk about bathroom safety, and then colleagues, you've got to protect people from injury. So I know Lillee and I are such advocates for this. So let's talk about stretcher safety in the emergency department. You know, I know that you're using other sensors that are out there. You are using some sensors, but I also know that there's many times that sensors aren't applied unless someone has a high fall risk, and maybe it doesn't, even their score doesn't rise to be in a high fall risk. Maybe you're using sensor pads on the floors when people actually stand up on the pad and it has an alarm that goes off. And oh my gosh, that's too late. They're already off the stretcher. So I just want to say that, you know, we have to be able to look at innovative technology. We know that staff in emergency departments have experienced challenges using fall risk assessment tools. And I'm going to differentiate screening from assessment tools for you, but these risk assessments are often, they're not complete, they're often incomplete because it doesn't capture all the risk factors. And sometimes they're even evaluated incorrectly in terms of risk. Now, the known faller, we just assume they're at risk for falls because they presented to your emergency department because of a fall. So patients are also assessed as fall risk may not always have a monitor sensor pad because we don't have them available on every single stretcher. And staff may not be able to even locate them. I know that this has been an issue. If we do have some that are available in the ERs, that staff have to go find them. And we know from safe patient handling and mobility work that if the equipment's there, people will use it. Nurses will use it, or more likely to use it, I should say. And sometimes it's even forgotten by the staff to use a sensor for someone who maybe even presented with a fall, not even just at risk for falls. And I know every one of you resonate back to COVID-19. Oh my gosh, during COVID-19, the fall rates went up. We had in emergency departments, we were out of beds. We had stretchers everywhere in hallways. You know the scenario. So my suggestion to you is there should be position alert monitors. I'm not calling them bed alarms like we do in hospitals. I'm calling them position sensor alarms. And you should keep up with innovation that is available on the market today so that every stretcher should be equipped with a position alert monitor. And these monitors can actually be connected to the nurse call system. They don't have to alarm on the stretcher. They don't have to alarm in the ER bay. But they should stay with the stretcher. They go with the stretcher. You know when they're connected to the nurse call system where that alarm is. You don't have to go searching for where that alarm is sounding. You have it connected to your nurse call system. And having this equipment available on the stretcher makes it more likely to be used when there's a changing condition that maybe you didn't need to have this alarm when someone first came into your emergency department, but now we've had a changing condition. We've had more confusion, more agitation, and we need to have this. So I always encourage colleagues for people to stay current with innovations and not just make decisions based on equipment you've used before, but to look at what's available for you now. And next, beyond stretchers,
could I interrupt you just a moment before you move on? Going back to stretchers, would you say that the responsibility for stretcher safety is everyone's? Because I know some of our colleagues can struggle with that. Maybe it's the biomedical department responsibility, or it's, we all have to be accountable for stretcher safety no matter what our role is. As you said, it's an interdisciplinary type issue. But I just wanted to get your thoughts about stretcher safety is everyone's responsibility.
Oh, absolutely. It is everyone's responsibility, and to make sure that the sensors are on for those who need to have them on. And that's and even radiology. You know, we know that there's issues with patients falling from stretchers, even on their way in radiology or on their way, but it is everybody's responsibility. And I'm so glad you brought me back to this, Lillee, because I also love for nursing staff to consider where that sensor should be. The pad, I like it under the shoulders, because when someone is turning, it's not just underneath their hips, because hips, they have to really move to get to the side of the stretcher. But we oftentimes in the emergency departments have people who are turning and the stretchers are too narrow. And even just with turning, that they can get too close to that edge of that stretcher and maybe have an unexpected descent off of that stretcher. But I also want to say that you should look to make sure that if you can, that you put one side of the stretcher against the wall. No one ever says that the stretcher always has to protrude out into the middle of the bay. You can move stretchers, and I do this all the time, because then you reduce the probability of someone falling off of a stretcher either side. So thank you so much for bringing that up. Absolutely, it's everyone's responsibility. And nurses aren't always there at the stretcher side.
That's right.
Everyone that's there.
And I have to commend you, because we all have alarm fatigue, but calling this innovation the century type of innovation, you know, it's a position type innovation, gets us away from that alarm fatigue. That I want to commend you for that, because I hope we start changing our terminology to position alert, not bed alarm.
Yes, and the measure of success should be that we have assisted stretcher exits, not unassisted stretcher exits. And no one, I will tell you, Lillee, is measuring that. The second opportunity, colleagues, to create a safer environment in the emergency departments, but also all bathrooms, is to redesign your bathrooms for patient safety. And I bet if you look at the picture that I present to you, that your bathrooms look very different than mine. You know, when you think about this, we need to have all of our bathrooms that have the space that's needed. They need to have higher heights of toilets. They need to have grab bars on both sides of the toilets, not on walls that are too far away, no vertical ones, nor horizontal ones that are not allowing patients to be able to use their biceps and triceps to hold on to sit down, push off to stand up. So if you look at my picture as well, look at all the metal that is gone. We have rounded plastic. So we've eliminated sharp edges. So when we look at bathroom safety, because patients will go and family members will take patients to the bathrooms and ERs as well, that they are not safe, and falls that happen in bathrooms are grave. So you need to have higher toilets that are at least 19 inches at the higher height of ADA. Higher height is better than lower height. And this is even for patients with low back pain or maternity patients. Higher height is better. Folding grab bars on each side of the toilet. You've got to eliminate sharp edges. If you've got metal sharp edges around even shelves in bathrooms that are there to hold, urine cups, eliminate them. You don't need to have them. People lose eyes because of that. They have lacerations when they hit things on the way down. Replacing metal, as I mentioned, with rounded PVC, making sure you have that non-slip flooring, and sensor technology. There's sensor technology that can be used in the bathroom, not having to have someone that's in the bathroom, where you have sensors that are placed on the back of wall of the toilet, where it lets the nursing staff know that someone is starting to get up from the toilet, and you don't even have to be in the bathroom. And those can connect to nurse call systems too. There's so much technology that's out there, colleagues. And the last opportunity that I want to talk with you about in terms of environmental safety is you have got to protect patients from injury when they fall, the David Oliver words. And you've got to get those floor mats down. And I know there is so much resistance to using floor mats in healthcare, but you've got to do it, because this is our best solution for reducing injury when patients fall in our care, whether it's from a stretcher, whether it's from a bed, whether it's from a chair or a wheelchair. There's all kinds of cushions that are out there, but as you look at this slide, I want you to know that there is a new innovative floor mat, HD Nursing from HealthSense AI, that is the only floor mat that has achieved FDA approval for the purposes of reducing injury when patients fall from bed. So just because you've used something in the past does not mean you shouldn't keep up with innovation and try again, but you have to protect patients, especially older people, from injury. And Lillee knows, as do probably you, that again and again in 2022, the Joint Commission let us all know that falls sentinel alerts were the leading sentinel alerts. It's falls with injuries, and that's voluntary reporting. So colleagues, we have to do something better. So I want floor mats to be a common practice and not a best practice. And this goes back decades. So let's go to our third objective, colleagues. That is to elevate the prominence of the emergency departments, which I have done for years within the continuum of care, as a critical point for fall prevention. And I'm so thrilled to talk with you about this, because I know, as we mentioned in the beginning, that our first priority for emergency departments is to triage. And that's why I have always been against using fall risk assessment tools in the ER. In the ER, what we need to be able to do is to triage based on presentation and etiology when someone presents to the ER. So of course, the first thing that is going to be done when someone presents with an emergency in an urgent emergent state, we're going to treat that injury, as I mentioned to you before. But then we have to diagnose urgent and emergent medical conditions, get patients stabilized, and then determine the etiology of the fall. So if someone presents again in the ER because of a fall because of a stroke, it's going to be very different than someone who was orthostatic or someone who was hypoglycemic. So you've got to still screen for fall risk. So that is the first priority. But fall screening and fall risk assessment are different. Every ER, every older adult should be at least screened for their fall history. And every adult who enters into that emergency department should at least have a fall care plan that started. So we start with screening, asking about history of falls. And there are tools for that, which I'll share with you. And then doing a functional assessment for those who can, even simply a single leg stance for those who might be able to do that single leg stance can tell an awful lot. I know myself, and treating patients for fall risk and running clinics for fall risk, I can tell an awful lot just by watching how someone walks and how someone sits down. So very briefly about these screening tools that are out there, these are not all of them, but there are some of them. And I just want you to know that, remember, we're talking too about those patients who are present because of a fall. You just put them at high fall risk and be done with it. But some of the screening tools that are out there, the Australia one, the fall risk for older people in the community, they actually ask about falls in the last year. Well, that's not what we're looking for in the emergency department. That's what we do in the primary care, is you ask about how many falls you've had in the last year. When people are coming to the ER, you need to know why they came to the ER because of a fall. But if they've had a recent fall that is maybe a biological marker that something is going wrong, that it contributes to those anticipated physiological falls. The Tideman screen tool, that's for the emergency department, that asks about 2 falls in the last year, which gets to the American Geriatric Society's guidelines for primary care, where you don't ask just about a fall in the last year. You ask for people who have had more than 1 fall or an injurious fall. So again, it's within a year. The emergency HD Hester Davis scale does not ask about fall history, but asks about indicators, clinical indicators that we know are really important for people who present into the emergency department that need to be then, because if they're identified, should move towards assessment. The assessment tools, there's a couple of those that are out there. We have the Memorial tool that's out there, the MedFrat, which does ask about history of falls. They ask about a mechanical fall. They ask about a physiological fall, not anticipated or unanticipated, but they also ask about people who are fall prone. And so that gets to a little bit more indication about those who actually present because of a fall. But interestingly, the Kinder fall risk assessment tool, this is a tool that actually includes those patients who actually fell, who came to the emergency department because of a fall, or had a history of a fall in the last year, or those who had a fall in prior hospitalizations. So those are different. They get into more of the clinical indicators. So I share that with you because I know some of you are using these tools, but there are also some of you who are still using the Moore's Fall scale, which has nothing to do with the emergency department. But still, you know, we have to get started someplace. But for the known faller, what's important about them is why they fell, the etiology of the fall, and then to go ahead forward with the rest of these tools if you're using them. So we talked about creating a safe environment. We've moved into the tools, but now we're going to talk about identifying those patients who have specific modifiable fall risk factors and implementing those interventions to mitigate and eliminate them. And that is our second objective. So when you think about this should be that should occur at every organizational level. So I have 3 populations I really want you to address in your emergency departments, in your healthcare system. And on this slide, these are patients who actually get admitted to your emergency department and they get sent home. And what percent of those? Over 60%, over 67% of your patients who present to your ERs who actually get sent home. And in all the emergency departments that I've worked with, I have always asked the ERs, if you have a patient that you actually send home and they came into your ER because of a fall, if you have the opportunity to do a satisfaction survey questionnaire with them, is ask them if they fell again after they left you. Because this is a real problem. Patients who come into the ER and they get sent home and they fall again and they get sent back to us. We know this happens with EMS and doing these lifted assists, fall assists up from the floor, that patients will fall again within 2 weeks, requiring EMS again. So these are patients, you should start a multifactorial assessment, but you have to not just ask about fall histories, colleagues. You've got to ask about injury risk. So what is injury risk? Those who are osteoporotic, those who are anticoagulated, those who have already had a fall-related injury. You've got to ask about injury risk, and that is what was done in the AGS guidelines years ago. Those patients who have fallen more than twice, more than once, and have had an injurious fall. But you can't protect from injury unless you know their injury risk. Then you're going to individualize the care plan. You're going to monitor their response to the care plan and modify it based on patients' response and change in conditions. But now we're going to start doing this education for patients in terms of education as partners in their fall prevention program. Every emergency department, this should be a common practice. Right now, it's a best practice, should be including all the steady resources and letting people know about the steady programs that have been around since 2013 from CDC, the National Center for Injury Prevention and Control, for home safety, because most of the falls happen at home, then in the community, then in our care. So we should be doing, for people who are being sent home, doing everything we possibly can do to help keep them safe at home. So the resources for balance, for medication review, for orthostasis, for vision, for exercise, there are so many resources that they have. Patients that are being discharged home should have a discharge plan that helps with follow-up for mitigation strategies for those risk factors that you've identified, and even with further workup, but also especially for the presentation, the etiology of their fall. Truly, there should be referrals to physical therapy and occupational therapy when applicable. And when you look at the literature, the best practice approach for home safety is getting an occupational therapist into the home to look at functional interaction within one's environment. And that follow-up phone call, if you can, to see if they've fallen since they left you. I mean, let's talk about safety and keeping them safe when they leave us. And then engaging patients with orders, educational materials, and continuing to monitor them with their primary care provider throughout the year. And I so hope that this is being done more than it is now. So this is my first population. So let's look at the second one. How about those who present to the ER because of that fall and they're being admitted? So these patients, you've gone ahead and determined the etiology of their fall, whether it's orthostasis, low blood sugar, balance loss, they had a heart attack, they slipped or they tripped. You're going to have your urgent emergent treatments that are being done, and then you're going to triage. You're going to start screening for other fall risk factors, their history of falls, their medications, mental status, balance problems, continence. How many people address continence issues? And then prepare for admission. There is not a single patient who comes into the emergency department because of a fall that everyone should know that this is a known faller. That's who gets signage in my world, is a known faller. Not someone who's high fall risk, the people who come in because of a fall. That I cannot tell you how much this does not get communicated on handoff to the accepting unit. It's not just the reason why they fell, but that they did fall. And every follow-on unit since that patient got admitted. This is our known faller. So this should always be communicated, the known faller. And then my third population that I like to help address and emphasize for you is the patients admitted to the ED department that presents to the ED without a fall, but is over the age of 65. So this is someone who comes to you, they didn't fall, but they're going to be admitted, and they're over the age of 65. So this is when we start doing not just age specific, but we know from clinical knowledge that these are people that need to be worked up, of course, for their chief complaint, but you still want to triage and screen for their fall risk factors. You prepare for admission and you want to treat them differently than just someone who is getting a score based on a screening scale for fall risk, low, moderate, or high, because you know people are over the age of 65. They are fallers. They're going to now start being at risk for injury. And these are the patients that, as you're preparing for admission, you want to start thinking about a toileting program for. Not everyone needs help with toileting, but those who do need to have help. People who are weak, people who have incontinence issues. You want to start creating a safe exit side for them. And this is a safety approach for mobility, where these patients are getting in and out of one side of the bed that is their stronger side. And this is going to be your floor mat side, is the safe exit side. And then look at surveillance technology that you may need to be able to use for these patients because you don't want them to overestimate their abilities and get up without you. So we talked about the patients admitted because of a fall, sent home. We talked about the patients who got admitted to the ER because of a fall. And we talked to you about moving into those patients who are presented to the ER without a fall but are 65 and older, that you've got to protect in a different way, certainly over the age of 65. But I want you to also think, colleagues, and Lillee and I have done so much work in this area, about those patients who are truly vulnerable. It doesn't matter what their score is on a screening scale. It does not matter. For people over the age of 85, we know from CDC, their data, that their leading cause of unintentional injury death is a fall. You have got to protect them differently than anybody else, just like infants and toddlers. People who are frail, you know, if they fall, they're going to break. They don't even have to have a head strike to have a delayed onset subdural. People who are known fallers, which we've spent time talking about, and I hope that this will be your new patient cohort as you go forward with your fall and fall injury prevention program. Anyone with a hip fracture that comes into your care, my goodness, you cannot let them fall again in your care and have another hip fracture. You cannot do that. You have to protect them in a different way. Floor mats. I even have one hospital right now that actually is beyond the VA that's using hip protectors for people who have already fractured a hip. Certainly for people who are dementia, remember that there's a wide range of severity for cognitive impairment, mild cognitive impairment versus severe. But those are patients where you've got to anticipate their needs, and talk to their family members. I took care of my mother that had Alzheimer's disease, and I could tell anybody how to anticipate her needs based on what I knew. But perinatal patients, and there's others that are out there, hospice that are fiercely independent, are going to do everything they can to stay as independent as possible. So I can't thank you enough, Dr. Gelinas, for allowing me to be able to present this, to be with you, to talk about this very important topic about fall prevention. And I so hope that everyone will really look at the emergency department as a point of entry for taking this on, because when someone comes into your care because of a fall, they got to talk about it. Remember, most patients won't even tell their providers that they've fallen, but when they come to you because of a fall in the emergency department, we have priority opportunity. So thank you, Lillee.
Your expertise, your passion, and I hope our audience understands that Dr. Oliver calls you a fallologist.
He did.
I fully appreciate that.
That was 2012.
That's so much fun. But you're so deserving of that important title. So I hope that our audience has taken away some key pointers to understand the importance of stretcher safety, bathroom safety, and injury prevention to make what is now currently considered best practice. Let's make it common practice. Every patient, every day, every way. So thank you for joining us. I want to one more time thank our sponsor, Colette Health, for providing the unrestricted educational grant to help us develop and present the webinar. All of the content today was developed and peer reviewed and is independent of our sponsor and meets the strict criteria we use for all American Nurse Journal articles. Colette Health solves patient fall worries for clinical staff. Their virtual patient observation technology supports healthcare systems and their staff with 24/7 virtual clinicians using human-centered AI software. Yes, Colette Health's AI observation technology empowers clinicians to constantly monitor patients at risk for falling. With Colette Health's solution, physical care teams can work smarter, reduce care cost, and improve patient outcomes. Over 170 hospitals and health systems use Colette Health's solution to prevent over 83,000 falls each year. They're rated 90.1% by class. Their solution reduces fall rates by 68%, calculated as saving $1.17 billion in fall-related costs last year. And one more important note, this webinar will soon be available on demand at myamericannurse.com/webinars. Another important reference for you, if you look at the related content box that's above the Q&A box on your screen, you'll notice some important references, including our American Nurse Journal continuing education article about known fallers, my recent editorial on falls, and the link to Collect Health's website. Do you have questions? And I'm sure you do. Type in your questions in the Q&A box. We'll answer as many questions as we can as time permits, or you can email us at webinars@healthcommedia.com. Feel free to share the link to this webinar when it's available on demand with your colleagues. All right, Pat, let's get to some of the questions.
I'm so looking forward to them. Thank you.
Dr. Quigley, the questions are rolling in rapidly, and I'll try to tackle as many as I can. Let's start with this one. As nurses, we are all taught about universal approaches to falls and injury prevention. You are a proponent of individualized care planning. How do we get started? How do we do that in our organization?
Oh, Lillee, I'm just like you, so glad to see these questions coming in, just like being able to help answer to respond to the chats. But this is one of the opportunities, colleagues, that all of us have, is to be able to move away from universal fall precautions. So my suggestions to you, colleagues, is to put them in their place. You know, realize that universal precautions are basically environmental safety interventions. They had a role when the Joint Commission first started fall prevention as a patient safety goal in 2007, but we're way past that. So put them in their place, but realize that even universal fall precautions have to be individualized. Like you don't put non-skid socks on a patient who can't feel their feet. So what I want you to do, as I shared in my lecture, is to stop this over-reliance on a score and a category of risk. Because all you're doing is labeling someone as low, moderate, or high fall risk in a category that's not going to get you to assessment of their risk factors are. So put them in their place. Create a safe environment, stop this over-reliance on the score, and start assessing your patients. Identify their fall risk factors. And then when you identify fall risk factors, then you want to be able to treat them. So that's when you're going to move into more precision. When you create a safe environment, the universal precautions, you're going to reduce accidental falls. When you start working patients up for their fall risk factors, now you're going to start helping to develop that individualized plan of care to mitigate and eliminate their fall risk factors. And then, of course, you got to protect people from injury. So when you start getting away from universal approaches to fall prevention to get to individualized care planning, you're going to totally transform your practice and have a change in your practice goals. Think about this. Having a goal of being able to mitigate and eliminate the fall risk factors that patients have, not just the falls, but improving their health and their function. So an example of this is just as easy as considering bed alarms. You know, bed alarms are often universally applied to everyone when they're high fall risk. Well, I want you to stop that. You know, use clinical indicators for bed alarms like cognition and mobility. So I want you to rely on your clinical judgment, and that's my suggestion. Put them in their place, but then move into nursing practice, nursing process, and for all of our interdisciplinary team members as well. That's a great question to start with, Lillee.
It really is, and it's all about individualized assessment because all patients are different. Now, there's a question here. You mentioned socks. Can you talk about footwear briefly? Do you recommend grippy socks? I think I know what you might say.
Well, you know, they have a place too, but they should not be universally utilized for patients, because actually there is research on footwear. And that research has even said that bare feet is even better than these non-skid socks that are ill-fitting and they twist. But if you're going to use them, make sure that you're using them on patients that can feel their feet. You should not put non-skid socks on patients who can't feel their feet, because then you're creating a tripping hazard for them. But there's infection control issues with them, because you see many patients that are walking around with non-skid socks. But I can tell you, in long-term care, for anyone who's on the call from long-term care, you can't put patients with non-skid socks on into their shoes, because then you start having skin problems. They have a place, but don't use them individually. Every decision that you make should be based on your assessment.
Pat, there's a question here that's, I think, a really good one that applies very broadly, and it's about, you mentioned fall risk tools, and the question is, what do you do for nurses when they're struggling with the fall risk tool if it's either overscoring or underscoring the patient's fall risk score?
Well, what I'd like to suggest to you, and I'm going to take you back to Dr. Janice Moore's first book that she published in 1997, Preventing Falls. And, you know, those tools that you're using for the most part are going to be screening tools. They're not assessment tools. And you should use your clinical judgment. If someone is considered high fall risk, because those screening tools don't include all of the fall risk factors that patients present with when you get to assess them. So if you know someone is high fall risk, make them high fall risk and get on to their fall risk factors. Use your judgment, because most of the tools in terms of sensitivity and specificity, the sensitivity is not that great on predicting who is going to be at risk for the anticipated physiological falls. That's what the tools are going after. So with the tools that you're using, put them at fall risk, but then stop talking about the score. Stop talking about fall risk, but talk about why they're at risk for falling. That's what we want you to do. My impaired vision, my sensory neuropathy, my postural hypotension. That's what we want to have conversations around.
So speaking of conversations, what's the best way to have a conversation with a patient, excuse me, that doesn't want to talk about their falls?
As I said in my presentation, I talk about mine and then help them to talk about theirs. So, you got to create conversations about them, because we all fall. Some of us fall more often than others. But, more importantly for me is those people who refuse to call for help. Patients have very different perceptions and perspectives of their fall risks and what a fall means to them. Older people who, as in myself, we fall more frequently than those who are younger. And so they kind of all fall together, if you will. But, many of you who fall, and I'm sure if we could all raise our hands and you could do this in these emojis, is how many of you have had a fall in the last year. You remember it because they're rare. But for older people, that's not the case. So, see, there we go. So when we want people to talk about their falls, and what I always say to them is that what's so important is that sometimes the fall can be a biomarker for a medical condition that's going on, and we want to help you. Because at some point in time, one of your falls could result in an injury, and we don't want you to be injured. We want to do everything we can to preserve your function, your independence, your quality of life. So that's why I am, as we started this session, I'm so worried about those patients who will not talk to their families about their falls. They will not talk to their providers, because there are so many risk factors that we have that are modifiable, that we can treat, and we can improve their health. We can improve their function. We can improve their balance. We can reduce their medications that are contributing to their fall risk. So I do everything I can. So that's why I ask all of you to create every opportunity to invite the conversation about falls so that we can talk with them. People shouldn't be embarrassed that they've had a fall. The first thing that people do when they fall is to look to see who saw them. So once you get over that, then we can start talking about why we fall. And I'm actually sharing that at the Rehab Nurses Association this coming year, but about my last fall.
Well, I think anything that starts that conversation and makes it very, very personable is really going to have an impact on the quality of the conversation between the nurse and the patient. So,
because we all fall. Yeah.
We all fall. That's right. We all fall. It looks like our audience really is resonating with your message around distinguishing between known fallers and everyone else. And one of the questions here has to do with MATs. Do you think there should be MATs for all fall risk patients or known fallers? So why don't you clarify those two categories again?
Absolutely. And I'm so glad. I thank you, colleagues, so much, because I bet that this has been a question for many of you about the floor mats. The floor mats are designed to reduce injury when people fall. That's their purpose, is to reduce trauma. And this is across all settings of care. And I can say that I know that there's been a message about this in the chat box, but in long-term care, they were using floor mats before hospitals did for preventing injuries from falls. So if it's a known faller that comes in and they've got injury risk, we're talking about people who are osteoporotic, anticoagulated, they've already had a fall-related injury. Now we've got not just talked about fall risk, we've talked about injury risk and injury history, because all of you should not just be asking about fall history in the last 3 months, 6 months, whatever time frame you're using, but you should all be asking about injury risk and injury history. So for those patients who actually are known fallers who get admitted because of a fall, oh my gosh, they're over the age of 65, 75, 85, they better have a floor mat down because they're at risk for injury. So the decision-making for floor mat use should be based on not just someone who's already fallen, but also the risk for injury. Because remember, the purpose of the floor mat, and they're not a trip hazard, they don't make people unstable when they stand out, and unless they have severe sensory neuropathy like my mother had, couldn't feel her feet at all. So you want to make sure that you know what their injury risks are and injury history is, and those are people you need to have a floor mat for.
And that's why individualized assessment is so important, individualized care planning.
But people make the mistake, even with universal approaches to fall prevention, it totally misses injury risk. You know, you've got to get to protecting people from injury because as you saw on our presentation, Lillee and I, is that patients are coming in because of falls and they're being rescued by EMS because of falls. And these are older adults that we talked about. So you just want to preserve life and preserve function.
There is a question here. What is your definition of an older adult? And I'll just say in my dissertation, as I was doing all that research, we don't refer to the geriatric population. We were just referring to the population that is older than 65. How do you define that?
That's where the guidelines are. That's where they start for over 65. And, you know, those guidelines started with the American Geriatric Society back in the 1980s. And, you know, we've gone ahead and moved up that age definition, but it really hasn't in terms of medical practice. But I prayed to live to 65. I'm going for 100. So I'm proud to say that I'm in that age group now. But yeah, you know, there's the very, very functional 65-year-olds who don't have a lot of comorbidities, not on a lot of medications, but you have to be able to determine risk in terms of vulnerability. There are those patients who are in their 60s and they're very frail. You know, they are living with cancer. There's things that are going on in their life. So age is not a factor for fall prevention other than being over the age of 85, because we know people over the age of 85, if they fall, would die. So that's why you have to protect them in a different way. And that's part of the presentation that Dr. Gelinas and I will be doing in September with you. But yeah, absolutely. Older adults is 65 and older.
That's what the evidence says. That's what my dissertation said.
And I made it.
That's it. I really like this one. Do you recommend increased intentional rounding for known fallers?
Well, well, it just depends. If there's someone who's cognitively impaired, yes. But for someone who's a known faller and they're cognitively alert, and we can have conversations and we're going to address safety versus autonomy. We're never going to call anybody non-compliance. Everybody, for people who are cognitively alert, we're focusing on autonomy, but always balancing safety with autonomy. So you have someone who, like me, comes in for a fall that I had because I lost my balance getting out of a car, for example. You know, I'm going to be okay. You don't have to do that intentional rounding for me. But for those patients who have cognitive impairment and you need to increase that rounding for them, absolutely you want to. Or people who come in and they're a known faller, they've got congestive heart failure. This is going to be one of my case studies for you, actually, in my article that I wrote. And it's on a diuretic. You got to do rounding more frequently than hourly or 2-hour rounding. Even that has to be individualized, colleagues. You have to use your clinical judgment. And I do want to say, while we're together, Lillee, that for everybody who's on this call, I want you to hear the importance of your clinical judgment, because clinical judgment is a level of evidence. It is a level of evidence-based practice. You don't have a piece of literature to support every clinical decision that you make. For those of us who have experience, it is different, the novice nurses versus those who are experts and on that journey to being experts. But use your clinical judgment. And, the Oliver article that we cited in the very beginning for the 4 recommendations, creating a safe environment, working people up for their risk factors and treating them and protecting people from injury. Dr. David Oliver and others said that clinical judgment is just as valuable and just as predictive of identifying someone who's at risk for falls as it is any of these tools.
And, individualized care planning and that exquisite nursing judgment combined for safer patient care. I want to point out, colleagues, that in the upper left-hand corner of your screen, you see a number of resources. Dr. Quigley's article on known fallers has Mr. Johnson's fall prevention plan. There's an example of an individualized plan there that you might find very, very helpful in your own practice. Let me take as many of these. Go ahead.
Lillee, I just wanted to add is that there's a partnership with patients and families too, especially for people who are cognitively alert, because I know a lot of you get frustrated with those patients who maybe refuse to call for help or whatever. And I always say, get to what's behind no, involve them in as partners in your care. And then when you're working together, then you can really increase the opportunities for keeping people safe.
It is working together. You've mentioned a little bit about how important those conversations are, especially with patients that don't want to admit that they've fallen. One of the questions, what are your recommendations for a known faller that requests privacy when toileting?
Well, for a known faller who's cognitively alert, they have a right to ask for privacy. Now, if you think that their condition is so unstable or they're on a new medication that's making them at greater risk for falls at this period of time, then you should have that conversation with them that because of the change in their treatment or their change in their condition, that you want to do everything you can to keep them safe. So those are patients that you do want to stay with. It's not everybody that needs to have a nurse stay with them in the bathroom, or everyone who needs to have a nurse that's in arm's reach in the bathroom. When you do that to everybody, then it's universal fall precautions and you're overburdening the nursing staff. So you use it based on your judgment of how at risk a patient is. But for those who want to have privacy, when my husband was recently in the emergency department and had to stay in the hospital for a while, he went to the bathroom by himself with his IV pole. So, he was functionally independent, cognitively alert. He knew what the risks were. But just make sure patients know what the risks are if they choose not to call for help and something happens to them. But value their autonomy. Help them to understand what the risks are, because patients don't understand that. They don't know how serious a fall can be if it occurs in their home compared to what if it occurs in your bathrooms where you have all this metal and all the things that they can hit on the way down. But, I also want to make sure, because we talked about the bathroom, Dr. Gelinas, is that there is technology out there, sensor technology in the bathroom that it can be connected to your nurse call system that allows privacy and calls the nurse directly to let them know, the nurses know that someone's starting to get up, not having to reach for a call light in a bathroom. So there's sensor technology that is very safe as well. So do all you can to be innovative and integrate technology. I believe in integrating technology to support us and help the nursing staff know how we can better help someone to assure that they have an assisted bed exit or assisted stretcher exit that we talked about, or assisted toilet exit. I hope that answered the question.
Well, I think it did, and you tell us if we didn't. Write us right back. This is just positive affirmation for you from Barnes Jewish Hospital. I liked how you referred to the stretcher alarm as a positioning alarm. You and I had talked about that when we were going through rehearsal for this webinar. The term bed alarm seems like a punishment. So positioning alarm seems like more direct about what it is that we're trying to accomplish. So just thank you for that.
Thank you. And I read a white paper on that too. I also wrote a white paper on the whole issue surrounding the bed alarms in hospitals, just like the side rail, or excuse me, in long-term care, just like side rails. There's an assessment that goes behind everything. You just can't have anything that's been in long-term care being used for fall prevention as a single decision without having an interdisciplinary team. So colleagues, as long as you're using your clinical judgment and you've gone ahead and done an assessment to determine the need, whether it's a quarter rail of a rail, bed rail, or half a rail, or even, putting the bed against a wall. There's nothing wrong with putting a bed against a wall. I move furniture all the time. I'm a rehab nurse. So there's lots of things we can do to create a safe environment. But I love the position sensor alarm. But think about this. And I actually had this conversation just yesterday with a hospital in Indiana, their falls committee. And I said, what if you think about setting a new goal? How about having a goal about the number of assisted bed exits that we had on this shift because we got there in time, because we used the alarm on clinically relevant patients and we got there on time. Let's measure it. Just like let's measure how many fall risk factors that someone presents in your care and how many that were treated and mitigated at the time of discharge. Who measures that? I mean, that to me as a rehab nurse is a better measure of success of fall prevention programs and care plans that are working than whether or not someone fell. We should all know how well their health has been improved and their function has been improved because they're in our care.
That's exactly right. A lot of our fall risk assessment, the tools that we use are embedded in our electronic health record. And they may not be exactly what you've been recommending. So for everyone that's listening today, if they want to begin to make some changes, and it's going to begin with the electronic health record, how should they start?
Oh, Lillee, I love that question because I can tell you, colleagues, that I have worked with organizations where IT has been a problem in trying to be able to move organizations forward with changing their fall prevention programs or products that they have. So what I like to suggest to you, these are my recommendations, is I would like to suggest that you have IT on your falls committee. They should be part of your team. When you find something that needs to be changed, they will work with you. We did this in the Department of Veterans Affairs. I have many colleagues that are on this call today from the Department of Veterans Affairs, which is my legacy and all that I represent in terms of, as well as the profession, but they will work with you. Just like you should not just be asking about fall history. You should have another question that follows about injury history by now in 2024. Oh my goodness. So work with IT, have them as a part of your team member, but expect support and rely on intention for progress to go towards clinical support for individualized population-based care. So involve them. But start with something new. Start with one thing at a time and see, it does take a burden to change EMRs. I know it does. You're not going to just go from one program to another, but maybe you'll take on postural hypotension. Everybody should be assessing postural hypotension and people are over the age of 65 before you start early mobilization. But I can tell you not everybody is, and that's nursing judgment. You don't need a doctor's order for it. So try integrating assessing for postural hypotension in your electronic medical record on admission. You know, try something, adding the fall injury risk, adding the fall injury history. Those are easy things that could be done. It's not a whole change, but start with something and make some success. Because once you change the EMR, you have to change the policy, then you got to educate people, then you got to roll it out. And that's the 24/7 staff. So anything that you do for enhancing your program, and I do a lot of work on and re-engineering and repurposing programs, is it does take time. So start with one thing and then work on it. Then when you find that you're having success, pick something else. And I know we're running into time, Lillee, but all of your questions are so important. And I have so much confidence in your work and how you can go forward.
So you have such a powerful message. The fallologist, your 40 plus years of experience has given us so much. But, you know, like you say, we're all in this together. And if you're an individual watching this webinar and thinking, how am I going to relate this in my organization? I would suggest your falls committee or any group replay this webinar. It's available on demand on myamericannurse.com. Replay this webinar with those that you need to bring into the conversation who can help you with the action planning going forward, and that might be a good place to start because you're not alone in this change journey.
I will help anybody, Lillee. I will help anybody. All you got my email. Anybody. I mean, I'm do this all the time. I'm here for you.
And we thank you for that. We are out of time. Please join us in September. Watch for the marketing for our follow-up webinar on such an important topic and how we address falls and injury prevention in a different way. Let's make sure we make these best practices common practice. Thank you again for joining us. Goodbye.